Tēnā koutou katoa, ngā mihi nui kia koutou. Ko ngā wairiki, ko Ngāti Apa te iwi, ko Bernadette Jones tāku ingoa. It's with great pleasure that I sit alongside these three champions, and there's been a lot of success in the news over the last few weeks, and it's all about the All Blacks and Aotearoa New Zealand is out there internationally, and you know we're getting huge praise for our people around the world. And I like to think that while there's cups and trophies given out to teams like the All Blacks, who have a lot of money behind them and a lot of people and huge teams and support behind them, we also have some of that hard work is going on right in our back doors. And it's with people like our three nurse champions here, who a lot of you will know what that's like, because you're out there doing it too. You're at the coalface too. So it's with great pleasure that I just want to let my colleagues introduce themselves.
Kia ora. I guess first and foremost I just want to apologise to those people I can't see behind the screen over here, but I also want to apologise to those who can. First and foremost, anō he mihi atu ki a koutou, he pai rawa atu ki te atu ki a koutou, me noho nei kei konei. Ko taki timi te waka ko manga haumi te au, maunga ko manga tapita. Te awa ko te aitanga maha ki te iwi, ko manga tūta marae, ko rawari tamanui te tangata, ko Lee taku ingo. Obviously my name is Lee Walters, and I've had the privilege of being a part of the team with Bridget and with Bernadette and with Tristram. I'm going to repeat that. I've had the privilege of being with Tristram and Bernadette because that's my Skyteam thing. I get to work with them, and I'm going to drag that out as much as I can because I probably never get the opportunity to be a part of something so great and so big. I work for Te Manaitoroa, and we are based in Tauranga, and we come under the umbrella of NMO, which is Ngā Mataapuna Oranga. So kia ora.
Kia ora.
Kia ora tātou katoa, ngā mihi nui ki a koutou. Ko Ngāti Raukawa, rawa ko Ngā Pui, rawa ko Ngā Te Whātua o ka iwi, ko Maraea Nathan aho. I've had a long relationship with Tristram and Bernadette with research projects going back a few years now. Otherwise, I wear the hat of practice nurse and a busy PHO out in Te Awa Kairangi. I've been a practice nurse for 14 years now, and I love coming away doing these research projects because I know the need is so great. So yeah, and it's been a great conference so far. It's been great. Sorry.
Kia ora, I'm Vicky Maiava. My nurse, Atarita Arnold, started this project and then had to remove herself kind of late into it. So I'm taking up on her work that she started, so I want to acknowledge that first. And I'm part of the Kotahitanga collective from Auckland, where there are three providers under that umbrella, and I represent Tūtaki Healthcare. So kia ora.
So I just want to ask you all a question that we have asked ourselves. So have you ever wondered what it would be like to step outside of the box? And that box is however you define it. It's that comfort zone that we've been trained in as health professionals or parents or board members or managers, whatever it is. We get upskilled, we get in there, we use our expertise, and we get rolling and we get going. Have you ever thought about what would it be like to try something completely different? Some of you probably have, and some of you have probably done something different. But we've been given the background, we've been given the scientific evidence that what we're doing for asthma and respiratory health in our country, and I know Smita's talked about in Australia and in other countries I've been to too. It's not working for some parts of our population, and today we can say it's not working in a lot of areas for our Māori people. So if we keep doing the same thing, and the collective we knew that we weren't going to get better results. Why would we keep doing the same thing we've been doing? It doesn't make sense, does it? So just have a little bit of a think about it. You've got to step outside what you're doing. But it's nice and safe and secure in that box. And you know, we grow up from being a baby and we're put in that little box and we're cocooned and looked after, and you learn a little bit step by step, and you know, if you step out you might make mistakes and you might not do it right. So, you know, I can understand why you want to stay inside that box. And, you know, bugger what everyone else is saying. Well, you know, why listen to Bernadette? Thinking outside the box, thinking inside the box, that's where it's at. Oh, I'm quite good in here, and even though I've outgrown it, I'll still work in here. But let's see what happens when you actually step outside the box and when you're at the coalface, like these nurses were, and we'll hear their story. Lee, pass it on to you.
Thank you, Bernadette. As I said previously, I work with Te Manu Toro, which comes under the umbrella of Ngā Mataapuna Oranga. Our GP clinics have been geographically located in high needs locations, and majority of those locations are where our Māori people live. So we provide kaupapa health services that branch from clinics, GP clinics that move into mental health, as well as tamariki order and community services, and I provide one of those community services. We have a population where we serve over 9,000 clients over 3 to 4 clinics. Our staff composition is 90% of our nurses within all our clinics are Māori nurses, and the same can be said about the staff in total. So I've been with Te Manu Toro for just over a year, coming up a year and a half. So like I said, I had the privilege of being a part of this project. So the project was looking at effective or enhancing delivery services to Māori living with asthma, and it was across the community. My specific roles, or I could be linked to 3 specific areas over the course of this project. Initially it was actually just focusing on the data collection, but it evolved into looking at Asthma Week and what are we doing within our clinics. And at a community level, I had the privilege of being involved with the AIMS Games. So today I will be talking about my experiences, I guess, my challenges, the issues, and also the enablers, what I experienced, my principles. I guess this whole project, what it's allowed me to do is to sit down and think about, reflect on what's actually happened, and it's been great. I've learnt a lot, so that's what I'll be sharing with you today, and I want to thank you for your patience. Data. Well, I guess data collection, to get data, you need to be able to do interviews, right? So how hard could that be, interviewing? You just sit down with a few selected people, ask them a few questions, summarise, put it into a report, highlight the common trends, end of story. Walk it apart. No problem, right? Right. So yes, it was a bit of my moment. Okay, so I really felt, it was probably the first point in this project where I really felt, wow, I'm like a dinghy in the middle of the ocean, and the swell's about 20 to 30 feet high, and the environment that I'm in is really uncomfortable because it's the unknown, and it's definitely the uncertainty. And I had absolutely no control over anything. So it was a matter of having to go with that. So yes, I did feel overwhelmed, and I felt quite anxious about it. But right there and then, you know, I thought, gosh, I can't do this. It's actually really going outside my comfort zones and taking my head out of that box that I didn't realise I'd created for myself. So you asked me to do the impossible. But I did decide that whatever issue and whatever boundary or whatever challenge I came across, there's always a way around, over and under it. And I think we as nurses, we all know that, and we've got to make that decision to do it. So I did have a change of heart. So what did I do to address that? Well, first and foremost, I guess I sat down and I took a very long, deep breath, and I did some very serious thinking. And I guess I developed what I refer to as my three-tier approach. So to be able to get the data, I needed to first engage with people. And I also needed to be aware of the systems within our clinics. And at the end was to, be able to retrieve that data, and usable data. So how did I do that? Well, first and foremost, I think, on reflection, I decided that this journey, everybody was going to be made a part of this journey, and everything that they contributed was going to be valued from my point of view, because I couldn't do it alone. It had to be a cooperative effort, and it was a team whānau approach. The second principle, I think, was about being transparent in this project. There were no dark corners in from where I was coming from, so that's what sort of drove me. Yes, there were a lot of, I was focusing, to get the data, I needed to sit with the doctors, with the GPs. Now, if you come from the old school like me, GPs and nurses, I suppose part of me was very much about the handmaiden, So that was a little bit intimidating. And who am I, for crying out loud? So I decided, instead of focusing on all the GPs, I would just look at the existing relationships with the GPs that I did have. And that's where I started. So instead of actually sending them out an email and saying, hey, this is the project that we're doing, blah, 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 I thought it best, and out of respect for those relationships, to actually do a face-to-face with them. And I liked that because it also gave them an opportunity to invite questions. And I felt that those questions were really quite pivotal to actually collecting the data, because it gave me an opportunity to recognise, address any concerns, any apprehensions, anything that may actually interfere with our time during the interview, in which I actually really needed to spend the majority on it, on getting the data and not so much addressing all these apprehensions. So that's what that did. I followed up every face-to-face interview with an email, and all it did was just to formalise what we had spoken about in a casual meeting. You'll see there and you'll think, research coffee, what's that got to do with anything? It had a lot, actually, and what it meant is that the non-clinical as well as the clinical stuff were very, very important in regards to this, because those who worked quite closely with the GP, I was able to go up to them and find out what kind of coffee they drank. So from that, I was able to decide whether they had lattes, cappuccinos, mochaccino, skim milk, full milk, sugar, no sugar. And that's what I ended up taking into my interviews. Yes, it was a token of gesture and gratitude and appreciation for them giving up their time and spending that with me, because for goodness sake, none of them were going to come in on their day off to do it. But they were very, very, very obliging. So that's what the coffee was. But it also had a secondary component. So coffee has what I think is it has a social component. So when you have coffee, you sit down with friends and you relax. So being able to give that coffee over to them created a transition on which they could move from being professional and just hanging with me from a personal level while retrieving the data. The non-clinical staff, especially the receptionists, were also really important in regards to booking GP appointments, is where I sort of did the interviews. They were able to tell me about which doctors worked what days, what hours that they worked, and whether it was actually good. It's not a good idea to go and see a doctor when they were rostered to do triage clinic or walk-in clinic. That only allows people 7 minutes, and no doctor's going to appreciate me walking in there and say, hey, let's have a chat. So we looked at where it would be appropriate, and ideally it was best each doctor was given time or allocated time to catch up on paperwork. So that's where I was decided where we thought would be best to sort of slip in there and have a chat with them. So that was and in the interviews itself, to retrieve data, you need to respect the people that are talking. You need to be able to listen to them and create that environment in which they feel free to be able to confide in some really, personal, professional challenges. And for them to be able to do that, it required one thing really. It meant I needed to keep quiet. I couldn't interrupt. I basically needed to shut up. Now for me, that's actually quite a challenge personally and professionally. So I think I needed to acknowledge that. But it's also about also being consciously aware that there may be some apprehensions with people. And it's important, I thought it was important to name it and say to them, for instance, a couple of GPs asked if our management were aware of what I was doing. And it was of great, for me, it was a huge benefit to turn around and say, absolutely, they're very much a part of this and very much supporting this project. But it allowed me to turn around and say, well, I can sense that there's some anxieties or there's some concerns around that. Would you like to discuss it a little bit further before we move on? And some people wanted to and some people didn't. But it gave them permission to say, hey, you guys are the drivers here, and I'm just the best passenger, and I'm learning very quickly to put my seatbelt on this ride. So it was good. I walked into this project with absolutely no interviewing skills, absolutely no idea how to format questions. Who can do that? I have no research background. I literally went in on a whim, and I believe that even that whim, I was able to create some really good feedback and data that was usable. There was data collection. The National Asthma Week, it was more about what are we doing in our clinics, and if we aren't doing anything, which we weren't, what can we do? How are we going to do that? And for obvious reasons, why are we going to do that? So I got the privilege to speak with a good friend of mine who is a nursing clinical manager at Te Maraea, Tracy Morgan, and I shared with her some ideas, and she was amazing. She said, yes, absolutely, let's go with that. So we decided the theme for Asthma Week this week in our clinic was going to be something blue. So we had different shades of lipstick that the staff were quite happy to wear during the week of asthma. We also had, those who didn't feel comfortable wearing the lipstick, they could wear something blue. So the lady with the blue top there is one of our GPs at Te Maraea, and she was more than happy to jump on board. So it was very much a whānau approach. It was a whānau approach because the idea of using blue lipstick or something blue, it was new. Everyone wanted to jump on board because it was fun and it was engaging. We took it from a we perspective, and it was really fun. So, some people had different blue lips with the darker and lighter underneath. But it was also, more importantly, it became a point of conversation. It was saying to patients and families that come and let's talk. They were often saying, what's up with the blue lipstick? And why is everyone wearing blue this week? And so we were able to, discuss that with the whānaus. And you'd be, which we weren't surprised, someone very close, their niece, their moko, their auntie, their sister, they all knew someone who had asthma. The competition approach that's there was, during the week of Asthma Week, I'd headed off to one of the other clinics and I'd shared about what we were doing in our clinic, which sort of spurred a little bit of competition. They were like, what can we do? So we threw around some ideas, and we're very much looking at next year we would probably do a competition in terms of each, whether it's staff and we attach ourselves to one of our whānau in the clinics, and we aim to see how many times we could go up or go around the mount in Tauranga over the course of Asthma Week. AIMS Games. Whew, man. Okay, AIMS Games. AIMS Games, I need to give you a bit of history behind that. It's a sporting competition that was started 10 years ago, and it was two principals within Tauranga, who are the principals of intermediate schools, which is the ages between 11 and 13, who decided to come up with this idea about let's do a sporting competition. So they literally started with 14 sports and 17 schools locally. 10 years on, it's now branched from being local and it's expanded nationally, and now it's at a national level in which we've had Hawaii come over, Australia come over, and they compete in these games. It's considered to be greater than the Commonwealth Winter Games. So that was quite exciting. Someone sort of said to me, said, "Oh, Lee, why don't you try and, get into the Ames Games?" And I thought, well, considering the magnitude, I don't think so. But then I thought, why not give it a go? You might as well just see. I mean, might as well get the big no formalised and framed and put it in my thing to never ever go there again. But to my surprise, they actually turned around and said, yes, 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 that's absolute great, jump on board, which is great. But what did that involve? It involved wearing a number of different hats. It really did. I guess one of them is sales representative. Now, if any of you think that you're not a salesperson, you are. Absolutely. Everything from trying to convince your children to brush their teeth and eat their vegetables, to telling your partner that it's vital to the family's well-being to shop, 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 shop until you drop. So we are selling everything, and this was no different. It was about selling it to everybody I came in contact with. Considering I was the only one a part of the project, I thought it was duly to consider myself to be the project manager. And part of that project managing was creating change and being a change agent. I guess my greatest roles within this is probably, if I was to narrow it down, would be the resource development and looking at the innovative logo design that I'd come up with. None of this would have been possible if it wasn't for NMO and Janice Cooker for securing a lot of funding, because part of the proposal was actually submitting and seeking funding. So I was fortunate enough for my PHO, my whānau water collector, to get in behind me and make this happen. Had it not happened, it probably wouldn't have had as much of an impact as, thank goodness it did, basically. So the resource and the logos. So at the sporting games, I put together an asthma sports toolkit, and in there were asthma checklists, which you can see there. There was the breather tech spaces, there was a book from Waka Cooks, and there was information about asthma, and there was also an emergency card, what I haven't featured there, which was put together by a third-year nursing student in Tauranga, and I had the privilege of advertising that to people. A lot of the whānaus really appreciated that because they were able to put that into their emergency kit. The cards that I created were focusing on 4 main messages. For the children to manage their asthma off the court, they would have better control on the court. So if you manage your asthma, you can stay in the game, you can play hard, you can enjoy it, and just reminding everybody that asthma is a team sport. Yes, the feedback that we got from a lot of the feedback that we did get was parents, coaches and managers believe that the children were old enough. We're talking about 11 to 13-year-olds. We're old enough to look after. They know it better. We don't need to be involved. When you talk to the children, that was not necessarily the case. So it was a matter of just sharing with the adults that breathing means that your asthma means you could potentially not breathe, and no one wants to know that they're going to be on that journey alone. So when you put it that way to the adults, things are like, oh no, we will definitely be there for our children, which is what we're after. The checklist was just letting the children know that you call time when you've got a sprained ankle. It was okay, giving them permission to say you can call time to use your inhaler as well. It's okay. And they were like, oh yeah, cool. The 2 Breathe campaign, and I did a lot of research on this, has come about because I wanted to increase the asthma awareness. And what I did is if you take the number 2 and you rotate it 90 degrees to the left and to the right, what you get is you get a picture of lungs. And inside those lungs, the children are playing, black silhouettes of children playing sports. So for the week, of asthma. We were, through the funding that we received from NMO, we were able to develop these resources. We were able to wear the Two Breathe T-shirts for the Two Breathe campaign. And we got known as the Blue Ladies during the week because we had blue, which is, anyone who knows the Blue Ladies song, that's just not what we were all about.
Going to sing it?
No, I'm not going to sing it. And so people got to know us that way. In fact, we had people asking if they could purchase the T-shirts as well.
Yeah.
I had a friend of mine who works with me also, Savitri, who is amazing. She's one of our administrators, and she walked with me through this journey. And what she did is I would give her a checklist, and she was my reminder. She was my backbone, and she kept me on focus. And she said, I know you're busy, but how about we go back to here? And I was like, yes, thank you. So she was quite pivotal. And we ended up doing the City to Surf run, which is a 12-kilometre run around the mount. And we were able to use our Two Breathe T-shirts. In fact, I won a spot prize because of it. So, yeah. And when we were doing these, part of which we're going to talk about the survey results after also, is that I developed these questions because I thought, how are we going to measure this, right? I have no idea what I'm doing, but I thought, we'll get some questions out there. We'll measure what we're doing. Luckily, we had Jessica, who works for the Asthma Foundation, who was kindly given to us to be a part of this AIMS Games also. Thank you, Jessica. And we learned very quickly, didn't we, within the first couple of minutes of actually going around and using the survey questions that I was using, they were useless. They were not actually giving us the data that we wanted. So I was able to utilise Jessica's skills with research, and she formulated some questions for us that were usable. And it was really, really interesting how quickly people were responding to it. And everyone that responded to it, who were a part of the survey, we were able to give them a sports kit and acknowledge them through that as well. Thank you. Here we go. To Kotahi, through Cheryl Davies, she was able to donate a whole lot of products, earthwide products, and we were able to develop them into prizes. And at the end of the survey, we pulled out the names, and these are the winning teams here who actually won those products. So that was really good. Some of the feedback we received about doing AIMS Games or during AIMS Games were for and against, and some were impartial. The blue highlighted comments that you can see there are comments, just general comments that we've got back from the families and the participants, the coaches and teams. Some of the families said, look, we have asthma educators and they never leave the clinic, so we wouldn't really know what they do, or we just don't know what they do. We live rurally, and they had absolutely no access to spaces whatsoever, so we were able to provide a box for them for them to go home. And some of the kids just said that they're just too old, they're just not hip, and they just have their own way of doing things. And I don't think they actually meant too old, because if that was the case, I was so out of their league, because it's just like, I'm only 10 years older. Yeah. So yeah, that was just some of the comments that came back. The Netball Association came back and said, hey, how come we haven't done this before? Yeah, so no one had actually done it before. The survey results. So Bernadette, do you want to speak about those?
Yeah, thanks, Lee. One of the questions that Lee and Jessica asked, and these ones are from the rangatahi, the young people, do you know someone with asthma? And pretty much, 98%, they either had asthma or they knew someone with asthma. I think it was about 33% had asthma themselves. So people say to me, well, why don't we just, as asthma educators, nurse educators, we just need to talk to those who have asthma. Why are you talking to all of the children? Why are you talking to everybody? Well, we've seen examples of why we need to, because for Māori particularly, Pacific, they go and talk to their whānau, they go and talk to their friends, they don't just talk to their nurse or their GP. And just keeping in mind how many people either know someone with asthma or have asthma themselves. You'd think they'd know quite a lot about asthma, but 20% know nothing at all. Nearly 70% only know a little, and about 13% said they know a lot. So we need to really increase that, because 98% should know a lot about asthma. If they don't, we're not doing our job. Would you know how to help someone having an asthma attack? Only just over a third say yes, they know how to, but 2/3 don't know how to, and these are the people out there when someone's having an asthma attack on the ground. So the results, just this snapshot of evaluation that Lee and Jessica took at these games, gave us a really good insight into what's happening.
Oh, final thoughts. I guess my final thoughts would be, that's where I started off. I had my head in a box and I thought, that I knew it all. But then I took it out and I realised what was involved by taking my head out of the sand, I guess. And yes, there were a lot of challenges, and yes, I was anxious, and there was a lot of apprehensions behind that. But as I said at the beginning, it was about trying to find solutions, and regardless of what the problem is going to be or whatever the issue might be, don't take a no for an answer and just find a way around it. Just do it without even thinking about it. I guess future steps, I guess it's a bright one. It's a bright one. A lot of things that have come about from this is, for me, is that, the invitation of being on a regional board, being invited onto a regional board. My networks that I've developed through the Sports Way of Plenty has evolved into something greater than I ever thought. I'm now involved with networks that are not necessarily health related, but they are opportunities of which we can raise asthma awareness and be able to look at it from a different approach. I really, really believe that the asthma approach should be taken like that we have a hot pink walk in Tauranga where everyone just comes along and dresses up and you pay an X amount of dollars just to have fun because you're exercising. I really believe that's the type of perspective we should be taking and engaging in regards to asthma. And I know within the Tauranga region, although it will be a challenge after this project, I think it's doable. I've also been given the opportunity to, in December, to attend the Wharekura Hakinakina, which is the equivalent to AIMS Games, but it's all Māori schools coming together throughout New Zealand to be a part of that. So I'll be there looking at the asthma, raising our asthma awareness there and getting us alongside those whānau. I guess for me, like Sharon was saying, they don't listen to us. And this project has allowed me to take that on board, really take that on board and develop something very different. As Sunitha was saying, and inhalers and its use has to be innovative and has to be different. And our approach has to be like that as well. Coming out of the clinics and getting out to the community where I was vulnerable, not them, tells me that that's exactly how they feel when they come into our environment and they come into the clinic. And I want to change that, or at least my practice. Cheryl spoke about, strength space, and it needs to be exciting, and it is about focusing. We don't need to focus on them ending up in hospital. We can do it in situations like the AIMS Games. Lance also, he was approached in the car park, and I want to be that accessible also. I want people coming up and saying, hey, you're the blue lady, aren't you? I want to know about the housing. I want to be that person. So over the course of this project, yes, much has changed for me, but I'm willing to make those changes for one simple reason. It's about the kids. Anyway.
Kia ora.
Shoulder, the blue lights.
That's just a snapshot. We've had a lot more conversations along the way, and the energy and work that Lee's put into it is amazing, as it has been with our other nurses too. So we'll just along the way, and the theme of this conference is the stepping stones, and I guess that Lee started talking about it, that, it's not easy. There's a lot of steps to take, and you need some help along the way, but Maraea's going to talk to us next and what it's like for her and along her journey. Thanks, Maraea.
Oh, kia ora.
Just put it right up.
Oh, okay. I'm going to start with saying the morning has dawned for a new beginning, which is the understanding or the explanation, the meaning of Takari Mai Te Ata. Takari Mai is our whānau water collective. We're based out at Lower Hutt. And just a bit about Te Awa Kairangi there. Te Awa meaning the canal of water or the channel of water coming through the middle there. And Kairangi is esteemed and, you know, a very fine channel of water coming through the Lower Hutt Valley there. And I'm going to be talking about the resources that Cheryl presented earlier and how we came about those. But again, Takari Mai Te Ata is a health service based in Lower Hutt. It's quite a large collective. It also involves Kokiri Maraea, Kiriana Olsen Trust, which is based in Seaview Marae. Other ones, of course, we deal with Māori Women's Welfare League, Women's Refuge. We have a GP clinic attached as well, Whāoranga o Te Iwi. We have tūkotahi Māori asthma nurses in service. We have Ngā Mataapuna, which also has services coming out of there. Manuahine, which is our breast screening and mammogram service. Ngā Kuinei Tamariki, who look after the children, and there's lots of other services. Ngā Tāne, health and social services. They also have education programs running from there as well. My role was really to help develop these asthma resources that we saw earlier and the methodology, and that was really to evaluate asthma data from the GP clinic at Whāoranga Health Centre and identify the gaps. I conducted qualitative interviews with health professionals, including nurses and doctors, to explore what they actually teach about asthma. And then from that we were able to develop the video that you saw and to be used alongside the cards. And we're also looking at there's a poster too that we are developing to place in the GP clinic itself. The rangatahi had a lot of involvement with that and still, and it's still, I look forward to that. Just a little bit about the health clinic. Whāoranga o Te Iwi has been established for over 14 years, as long as I've been there. It is a service that came out of Seaview Marae, Kokiri Marae. They wanted a clinic to service their population. However, we went and eventually, after 2 years, I think, in the process, got an actual GP clinic, but they based it in Wainuiomata, which is over the hill from Lower Hutt. There are currently 6,500 enrolled patients there. We have 4 full-time doctors and 4 full-time nurses, or not full-time, a couple of part-time as well. The breakdown there is currently 65% of that population being Māori and Pacific, and it's quite a high needs population. Some of the issues that I faced when I was doing those interviews, that it did pop up a lot, that asthma has not been a priority or a concern for a long time in this practice. Another one, I have not got the time to cover everything, let alone identify any issues that might come up. I couldn't find an asthma plan on MedTech. No. Just in saying that, just the way our clinic has been over the years, 2 years for one doctor in a clinic like ours, very high needs, very busy. 2 years for a GP there is a long time. So we tend to have a high turnover of staff. The nurses seem to be stable, but the doctors, there is a high turnover there. By the time they do find all these things, they've moved on. I feel our patients are well covered in giving asthma education as we work in partnership with Tūkotahi Asthma Trust. And they also follow up on our patients. And that's an issue because it's a unique relationship we have with Tūkotahi in that they are based within our clinic. Clinics all over the country don't have this availability to them. So they've become quite reliant on the service. And we've used it. Have lots of asthmatic patients who do not have inhalers or who are not refilling their prescriptions often enough. And of course, Tristram's highlighted a lot of these things in his previous talk. A question was asked, is health literacy an issue with asthma patients? And how do you address it? Some of the answers, yes, definitely. But then with all ethnicities and socioeconomic groups, that was a question. I'll address that again later on. I try to reiterate, use repetition of the same message. I go back to basics. These are individual discussions with doctors. I go back to basics and I educate about spaces, preventers and emergency plan. Sometimes emergency plans. That's a big sometimes. I discuss important information only. I get the patient's input always. And again, it could be better to have this reinforced by the Tūkotahi nurses who have the time. So that's a big theme in our clinic, just within our clinic. Sorry, Anne. Where do you want to access asthma guidelines from? And sometimes, at one stage here says, do you access asthma guidelines? But most of them knew where the health pathways were. They would sit it on their toolbars on MedTech, where they could access it when they needed it. From best practice tools in MedTech, online Ministry of Health websites. Some preferred printouts, hard copies, and they're generally the best practice journals, which are now actually available online. We need quick access of information, so online is best, and easy to use systems, which I now realise that there's a lot of. I've got to find. So practitioner key asthma messages from this from the future for the future asthma resources. Big one, smoking. Stop smoking. Don't start smoking. Changes. Secondhand smoke. Dangers. Healthy lifestyles came up. Healthy homes came up. Weight issues, eating, activity. Use your preventer inhaler, and that was highlighted in the DVD. Importance of correct inhaler use, again that came up. Use keep inhalers where you can find them at all times. These reports come in from the doctors. Did they have any ideas for the resources? Number 1. Clinic-based asthma nurse champion. We'll go over that later, what that will consist of. Web design input. There's lots of web design inputs out there, but we've just got to access them, I think. Phone apps for parents and for the rangatahi, with key messages like when to see your GP, when you should be presenting, when you should be going to ED, how to take your inhalers. And of course, there's lots of funding issues behind that to develop that. interactive puzzles, games for children, something that they can play with their peers. Had to be fun. Some of the challenges that came up, like Lee said, you had to get their buy-in. Buy-in was important. The staff, were reluctant to and resistant to answer any questions if they didn't know what it was about. Needed to build that understanding of the research and the role that I was doing as an asthma nurse champion, and that was to break down the resistance. Staff attitudes, it's not just a Māori issue, and I'll talk about that later too. Accessing asthma data from MedTech, all the doctors had their own systems in place. There was nothing standard. Conducting interviews, time is always there's always time restraints. Doctors are very busy. I had to book an appointment for each interview. So it wasn't a real in-depth one because they only have 15-minute appointments. And I had to book in when I could, when there was a space. Results. We developed the asthma talking cards for health professionals. We involved rangatahi in the whole process about the messages that they wanted on it. And then we designed the posters and the talking cards and the DVD. Okay. Now the asthma nurse champion role. I'm sure there's lots of practice nurses in here. And the benefits of an asthma nurse champion. Well, we know at the moment that, there's going to be these long-term conditions. There's going to be a big focus on long-term conditions. So this fits in well with that. It also worked in with the children's health networks, which the clinic is part of too, with the Hutt Valley DHB. Provides health literacy for our health professionals and whānau. It's not just a whānau thing. There was a talk further back about the role of the doctors, the role of the nurses, and how we do that. Monitors whānau with asthma routinely throughout the year. I know there's a Care Plus program, which is every 3 months, and it's a monitoring process. This has to be like that. And I think there was a doctor earlier this morning that said once a month for 3 months and then a gap for 3 months. There needs to be something like that for their monitoring. Asthma nurse role would be to access data as well. The most recent hospital admissions, they come through the fax machine or the MedTech, who's been admitted recently, and she has privy to that information, and that's for follow-up purposes. Benefits to the practice. Okay. It does provide the education they need and the understanding behind it, and it reinforces. So, because the asthma champion has time, it's time. Is a go-to person who has total focus on this particular area. I don't know, in the future with the capacity, because this is huge. It's huge. It's going to be huge. I know there's a lot of focus at the moment on diabetes, CVDRAs, and this is going to be just as big, if not bigger. But that nurse champion needs that full focus on this whole area. Be able to address the smoking, the housing, and do the needs assessments and refer to the services to help them. And then work towards future. There's going to be national health targets and indicators via best practice. And that lines up again with what's happening with diabetes, what's happening with CVDRAs. We still look forward to that. She can use the practice data and be able to find out what we're doing is effective. Again, to the community, doctors have become really confident And that's just with our relationship with tūkotahi, with the asthma assessments that have been done from tūkotahi. And doctors and nurses, using best practice guidelines for patients with asthma. And again, it's a unique relationship in that, like I said, Anne is based in the clinic. She is already the go-to person. She is already, she's the one that's been following up. And in the future, then Anne can just move out and do all the beautiful work that they do out there in the community. More involvement with asthma research improves asthma outcomes for whānau. So research is highlighted there. Doctors are open to trialling new medications from that relationship, and that's come from the recommendation of the asthma nurses. Doctors are happy with asthma patients that are being followed up on a regular basis. And from all this, of course, referrals to tūkotahi have increased. Okay. Future opportunities. We've been talking about this. Commitment to be involved in future asthma research opportunities are there. A Māori health plan now embedded in this practice. Developing an asthma health literacy culture within this practice with the health professionals. Have high performing best practice organisation that works in partnership with the community. And that's it. Thank you. Maraea.
Kia ora, Maraea. And I think you've shown very clearly that there's a lot of steps, there's a lot of barriers. It's not an easy pathway to get there. They've had a lot of challenges in this very high needs community and this practice to remain open and serving this population. But they've worked as a team and they've tried to, like Lee talked about, looking around these barriers and trying to overcome them. Last but not least, I'd like to hand over towards to Vicky, and we've moved around the motu, around the island, and we've come to South Auckland just to get a bit of a taste of. Is it the same? Is it different? Do they face the same problems there, or what can we learn from the community, Māori Pacific community here?
Okay, so as I mentioned at the beginning, I did have another nurse that was doing this project to begin with, and Turiki is part of a collective, as I said, where Papakura Marae and Te Kaha are part of that as well. We are a GP clinic which actually started 20 years ago by a group of Māori midwives that wanted to go back to natural birthing, and found quite quickly that they needed other support services. So they, the GP service, Family Start, and a lot of other support programs for women were incorporated within Turiki. We're really lucky at Turiki. We actually have a COPD asthma nurse specialist that's there 2 days a week. I feel that, considering it's not part of our targets from our DHB or from our PHO, that our patients always miss out. When our COPD asthma nurse specialist started, her main focus was on our COPD patients. And we noticed really quickly that a lot of our asthma, especially the children, were being missed out. And so we started moving them into her, and she was like, and I said, well, these are the ones that need it. And so she works alongside both of those. But for this project, one of our contracts is the rheumatic fever program that Lance was talking about this morning. And so Atareta works as a rheumatic fever nurse in one of the schools. And so we suggested that she do that in her school. So her school is a huge school that goes from kohanga right through to secondary. And on site of that is also a kura that is unique in itself in that it's not accessible by the school because it's run by a different board. But the junior school's here, the kura's there, and then the rest of the school's down this end. And so it was a chance for her to actually interact with the intermediate and the high school and get that school nurse involved as well. And so when she spoke with her children, with her rangatahi, most of them were around, what's your interests in life? What is it that keeps you motivated and out in the community, what is it that you do? And so a list of suggestions were there, and then there was, okay, so for South Auckland, I see that she put beautifully that we're a vibrant cosmopolitan centre and home to the largest Polynesian and Māori community in the world. But we also have a huge low socio-economic group that housing of it's a really sad kind of place actually, Māori, within our community, in that we do have overcrowding, we do have housing issues, an AFI program that we would love to put every child on, but they don't meet the criteria. So yeah. But we also have out in South Auckland a really high percentage of under 18s. So even within our clinic of 5,000, our biggest age group is our children. So yeah. So some of the interest, and as she goes on, is what gets our rangatahi going is music. Where we come from, we have a huge arts centre that do local plays and productions, and we even have a Māori radio station at one of the Maraeas down the road. So it's one of those places where, what is it that you interact with? How do you communicate? How often do you actually get around and do access a lot of these centres to within the community? And what are your role models? Who are your role models? So she built the trust around them when she started this project around actually getting to know what they liked, what it is that they did. And then she got into, what is it with your asthma that you're missing out on? So the school was approached. We got a group of 12 rangatahi that she worked with. The hardest thing was actually getting into the school to start with, so you had to get permission from the director to actually enter the school, and then once they were on board, then you were able to move around. We got the school nurse involved, and then it was getting the parents to consent and then working through with the data that you had. So we do acknowledge the school because this was all done during the school hours, and so the children were allowed to move to meet even when I took over during their school day, and so we do acknowledge the school for the support that they did give. They also talked about some of the barriers. So these are children that have always had asthma, have had hospital admissions, who are compliant with their medication. So they know that they've got reliever, and they also know that they've got the preventer that they're supposed to take. But that doesn't mean that their life has been easy. So none of them had ever been referred to a asthma nurse specialist. So none of them had an action plan. They only saw their GP for their asthma inhalers, and so any information was crossed over from him to them. A lot of the information was, they said, professionally done, and so it didn't really capture their attention, and so it was really hard for them to engage. A lot of them didn't even know who else and their friends actually had asthma because they didn't talk about it. So it was a real individualist kind of disease that they live with, and that they have whānau that support them, their best friend. And I'm really surprised about the champion thing, because they all said the same thing. There is a friend that they have that watches over them, that makes sure, you know, if they start getting wheezy or short of breath during the day, that they'll go, hey, have you had your inhaler? Or do I need to take you down to the school nurse? And so that was really interesting to hear that was actually something that was recognised by other speakers today as well. And that they said when they were in primary and intermediate primary school, so the primary's up there, their asthma support was actually their GP. Once they got to intermediate and high school and they could access the school nurse and the GP clinic that's actually on the school grounds, they became their place of where to go. So it made it easy for them to access their inhaler, so they didn't have to run out. You know, one of the, further on, one of the mothers had I'll see if I can find it there. My mum said, don't use your inhaler, just breathe. So, and yeah, people are shaking their heads, because that's what they do, you know. You know, it's that whole thing around, you can do this, you're getting older now, you should have outgrown it, you know. So there's that whole message around, you know, the family, you're really loud when I have to sit next to you when you breathe, and I hate it, you know, and can you go sit on the other side of the table kind of stuff. You know, they said when they sleep, the other members will say, oh, you kept us up with your coughing all night. And these are families that have actually grown up with these people, so they know them, and they've grown up and they've lived with them every day, and yet they still don't know how to deal positively with them around how to support and help them. You know, the young girl that said that she has to stop playing netball and come off the court to, you know, to get a puff of Ventolin. Like Lee said, if you sprained your ankle, if you fell over, the umpire automatically goes time. If it's for your inhaler, they look at you as if to say, well, you shouldn't be on the court. You shouldn't be playing, you know. And so it's making the rest of society realise that these children are actually entitled and should be encouraged to participate. The singing, you know, the singing group is an amazing way of looking at that. We've got exercise groups with our nannies that we have at Tūtaki who come in on Thursday, who are diabetics, but they also have to get up and do line dancing, which is great for their breathing, you know. So there are ways that we can support them, and these rangatahi really need to be able to get some of these barriers removed, and from their own whānau as well. So some of the ideas that they came up with was around providing information that is something that they would be interested in, so that their age would look at and go, oh, cool, I really want to read about that, is using celebrities. So in South Auckland, a lot of the youth know of people that have been through their schools or that are in their community that have become warriors or All Blacks or netball, you know, silver ferns. And those are the people that they suggest that we get them on board. When you look at how many appointments, I mean, you look at the All Blacks who've come back from the World Cup after how many weeks away, and they've got to go to every town to, you know, they've got 3 main ones, but there will be all the little ones in between that they're going to have to go back to their own personal clubs, and that it's really hard to get somebody to find their time. What we want to see is them become their own champions. What we want them to do is you know, like where they talk about a cool place in their school where they could go to, they would be the cool ones. They would be the ones that would be there and encourage any of the other students that come in with asthma or who are needing support to sit with them and say, you know, when I first came here, this is the information we had, and yeah, it isn't much, but what we've created is this new lot of information and this new pathway, and build on that. And, you know, a lot of it will be the seniors, But what you're looking at is that the seniors teach the younger ones that are coming through so that they become the seniors, and that's the follow through. And it's funny because that was what our group suggested. And when we flew into Wellington yesterday, Jessie was telling us about a program in Australia about the triple A's. Yeah, you know, same kind of thing. And I was like, whoa. So there's all this like-mindedness going on, but it's a gathering of it and actually making it so everyone's talking the same language. Everyone's moving along the same path around that. And so this is the school drop-in. This is the asthma clinic. And I think this is one of the main things that they can do for themselves, you know, so that they are educating whatever it is that they had, that they felt that they didn't have when they were younger, they could put together for the next generation of children. And I think that's where it has to start, to change the attitudes of our next generation, is that we start with... I kind of always think that if when you hit 18, we've lost them. We need to get to the next age group coming through. So if we can get the 17 and 18-year-olds to make up all of this information that they want to share and then pass it on to the year 9s that come through, then that's where we're going to capture them. And if they get the next 5 years of being educated and supported and helped along the way with the GP and the new specialist and proper plans put in place for them, then that's when we're going to make a difference. So that when they start having children, they're going to know, they're going to have that support, and that we're not going to have this next lot of, you know. I remember coming here 2 years ago and saying, with my CEO, and saying that a lot of children aren't actually diagnosed with asthma properly, and 2 years later we heard Dr. Lance Sullivan saying they're still not being diagnosed properly with asthma. And so, you know, that's the biggest thing. I had a grandchild personal story, who went to the doctors on Monday, and the GP said to her, well, my suggestion is 5 weeks old, is if they're really wheezy, then give them 4 puffs of an inhaler, and if they improve, they've got asthma. If they haven't, it's bronchiolitis, so, you know, there's not much you can do. I'm like, does that help? You know, does that really help you know, so at 5 weeks we can say, okay, because she's got, you know, not she, he has got asthma. I mean, that's not a proper diagnosis, and that's not a proper treatment plan. But that's what we're still getting out there with our GPs, so, you know, we need to go back to basis and say, this is the plan, these are the information, and this is where we need to go, and this is where we need to make a difference. Same thing, train the students to support and have rangatahi engage with an asthma nurse specialist in the community. They're there, and we don't utilise them as much. And they, as everyone here agrees, they need to become part of our primary health target that we have to meet with our DHB and our public health, our PHOs, because that way it'll make a real difference, and they won't always be under the radar. Thank you.
So I guess one of the key messages here, we've seen the journey of these 3 pioneers, I guess. I see them as pioneers because they've stepped outside their little box and their clinics, and they've taken their services to where the rangatahi are, and they've not waited till the rangatahi gets sick and end up having to come in with acute episodes of asthma or ending up in hospital, and they're looking at a different delivery, a different way of delivering asthma services. But we can't do it. There's not a lot of Māori nurses out there. You know, we're very privileged to have 4 of us sitting here at the table. I feel privileged to have them here with me, but there's not a lot. The workforce isn't very big. We actually need everybody out there. We need the community alongside of us. They don't need to be nurses to do education, community health workers. Some of our parents, some of our whānau are fantastic educators. We need to listen to them. I guess that's the message. And if you listen to the nurses here today, they went out and listened not just to the whānau, they listened to the children, they listened to tamariki and rangatahi. They know. We've got to listen more to them. Because life is not meant to be lived inside a box. And it's not meant to be at work, we're not meant to stay inside our box. So that's my challenge. Get out there, get out of that box.
Okay, thank you very much. Okay, unfortunately we don't have time for questions, but I suggest if you have any, you catch up at afternoon tea or this afternoon or tonight with the panel. So thank you very much on behalf of the group here today, and we have a small gift here for each of you as well. I'll just pass it. Okay.